Greetings and welcome to Hangouts with HIVE. Today's topic is Towards Health Equity, Understanding the Role of Structural Racism. My name is Yamini Oseguera-Bhatnagar at HIVE, which is a hub for positive reproductive and sexual health out in San Francisco, California. A little bit about HIVE. Since 1989, HIVE, which was formerly the Bay Area Perinatal Aid Center, has provided preconception and prenatal care to women and couples affected by HIV. Since 2005, all babies born in San Francisco have been free of HIV. Our mission is advancing reproductive and sexual wellness for individuals, families, and communities affected by HIV in San Francisco and beyond. And our vision is a place where people affected by HIV, a world where people affected by HIV, have safe pregnancies, reproductive autonomy, access to state-of-the-art healthcare, and enjoyable sex lives. A little bit about Hangouts with HIVE. Hangouts began in November of 2015 as a way to learn and share the good work of innovative advocates and providers with a commitment to HIV prevention. Since 2015, Hangouts has featured the vision and the work of many, many champions from all over the United States. In 2018, Hangouts with HIVE took a closer look at the rates of HIV acquisition among women. We brought experts together on the ways women access and engage in healthcare, manage competing priorities, navigate structures, and are impacted by structural racism. We talked about how to care for and support women impacted by substance involvement, incarceration, transactional sex, all while contextualizing racialized health disparities as a structural failing, not an individual problem. More on today's topic, which is Towards Health Equity, Understanding the Role of Structural Racism. We're here to learn and share about what it'll take to move us forward towards health equity. Let's center the work and the lives of all the women of color whose shoulders upon which we stand and who made it possible for us to have these conversations today. But what will the future generations say of us? That's my personal question. As we're listening and learning from our panelists today, let's think about our own work with women. What does it mean that many women in our communities and those who we care for in our clinics, in our agencies, and community-based organizations experience both overt and structural racism in their daily lives? What more do we need to know, and what do we need to do differently? A couple of tips for viewers before we delve into the content of the hour. We will broadcast for the next 1 hour, as you know. During this time, as you listen to our panelists, please think about questions that you have for them and ask them in one of two ways. One is in that chat box on the YouTube page, or you can text 415-842-2722. That's 415-842-2722. If you like what you're hearing, we're on Twitter. Come find us. We'll be at #HangoutsWithHIVE. Also, #HealthEquity. And if you missed this live broadcast and you're actually watching the recording, you can click on the link in the comments section to find a list of resources relating to this Hangout. So today's discussion is going to be in Q&A form, as the last couple of our discussions have been. We'll then have time for some audience Q&A. And here are our superstar panelists for today. We'll start with Monica McLemore. Monica is focused on understanding the factors that influence health, well-being, and livelihood of low-income and women of color. Using the intersectional human rights middle-range theory called Reproductive Justice, she designs rigorous studies that answer novel and complex research questions because RJ is simultaneously a theory, practice, and a strategy that is grounded in 4 principles. Those are: every person has a right to decide if and when to become pregnant and to determine the conditions under which they will birth. 2, every person has a right to decide they will not become pregnant or have a baby, and options for preventing or ending pregnancy are accessible and available. 3, individuals have the right to parent children they already have with dignity and have the necessary social supports in safe environments and healthy communities, without the fear of violence from individuals or the government. And 4, individuals have the right to disassociate sex from reproduction and their healthy sexuality and pleasure, and that healthy sexuality and pleasure are essential components to whole and full human life. Boom. Dr. McLemore, thank you so much for joining us.
Thank you so much for having me. I'm really grateful to be here.
Fatima, Hyacinthe. Fatima leads the training and capacity building work of the Black AIDS Institute. In this role, she facilitates training about PrEP, medical mistrust, and other topics relating to social determinants of health. Fatima also liaises with various chapters of the Black Treatment Advocates Network and leads the Institute's programming for Black women. Fatima hails from Brooklyn, New York, and is a proud daughter of Haitian immigrants. Her previous position was working with the community she came from as a special assistant to the commissioner in the New York City Mayor's Office of Immigrant Affairs. In this position, Fatima handled special events for the commissioner and provided support to senior staff. Fatima graduated from Harvard University with a degree in government and global health, which has continued to inform and guide her work. Fatima, super thankful to have you. Thank you.
I'm very grateful to be here, and I'm super excited for today's conversation.
And then we have Zaya Malawa, who is a pediatrician and public health professional committed to improving health outcomes for children of color. Upon completing her undergraduate degree at Columbia University, she earned a medical doctorate from UCLA and a master's degree in public health from UC Berkeley. After a decade of practicing medicine in safety net clinics, Dr. Malawa has become acutely aware of the toll racism takes on Black and Brown communities. She recognizes that, in addition to delivering high-quality medical care, social justice advocacy is essential for promoting health within marginalized communities. Currently, Dr. Malawa sees patients at Mission Neighborhood Health Center here in San Francisco, and she works for the San Francisco Department of Public Health, leading a collective impact initiative to reduce racial disparities in birth outcomes. Welcome, Dr. Malawa. You're on mute.
Try again. Thank you. I'm really excited for this conversation today.
So with that, we're just going to move right into our discussion. We've got so much to talk about that we almost didn't start on time because we were talking about it backstage. So what we will do, I have a few questions for each of our panelists, and what I'd like to start off with is questions about data. So if I could ask Fatima to just set us up with a little bit of the data around HIV prevalence among women, and particularly women of color. Does that work, Fatima?
Absolutely, yeah, so thank you. I'll just give some quick information just to kind of frame where we're coming from when we're talking about disparities related to HIV. So at last count, Black women have a 16 times higher prevalence of HIV than white women. When we're looking at HIV, we're looking at specifically in the United States, in the South. We're also seeing when it comes to accessing prevention methods such as pre-exposure prophylaxis, which for folks on the line is a pill that you can take once a day to help prevent HIV. It was found in March of this year that 44% of folks who could benefit from PrEP are Black. So that's not disaggregated by gender, but 44% of folks who could benefit are Black. However, only 1% of PrEP prescriptions went to Black folks. When we're looking at the Latinx community, we're seeing 25% of folks who could benefit from PrEP are Latinx. Only 3% of those prescriptions went to the Latinx community. And when we even take a step further, if you're to look at a map of where Medicaid was expanded and where new incidences of HIV are taking place, it's the same place. It's, again, the South of the United States. If you're, we go to Essence Festival every year at the Black AIDS Institute, and we do surveys of Black women talking about their sexual health, HIV prevention, and generally, where do they get their information about sexual health? And what we found is that even among women who are going to their annual physicals, going to their, OBGYN appointments, doing everything that you're supposed to do, they're not even getting asked a question about whether they want an HIV test. And that's linked to a lot of things about Black women's sexuality, that kind of perpetuates in all these different manifest ways and ends up with the numbers and the disparities that we see today. So that was kind of a crash course. I can answer more specific questions later, but I want to get into the meat of the conversation.
Thank you much. I'm gonna ask Monica to talk a little bit more about overall reproductive health outcomes and disparities that we're seeing.
Thank you, Fatima, so much for that overview specific to HIV. I think it's really important that we understand that everything I think all of us are going to say is really grounded in an important idea, an important notion. So I'm going to say that before I make my comments around data. You know, people think about Black women seeking health services as carved up in a lot of different ways, but I would like to suggest that they're the same women over time, whether you're looking at birth or HIV risk, whether you're looking at abortion, whether you're looking at infertility services. These are just different, there's the same group of people at different time points in their lives. So we need to stop sort of thinking about the fact that we're seeing either disparate outcomes in birth or in infertility or in abortion rates or in preterm birth or maternal morbidity and mortality. These are the same individuals, just at different time points over our lives. So I think it's really important to sort of make that point. I will tell you that, in science, we like to name many of the things that we talk about from a very deficit model. So I can tell you that, Black women are overrepresented in unintended pregnancies. In fact, half of the abortions that are received are disproportionately provided to women of color and to Black women. I can also say that amongst preterm birth, we're overrepresented in not only the babies who are born too soon, but also in maternal morbidity and mortality. And in fact, we've seen the CDC statistics that Black women are more likely, 3 to 4 times more likely to have a maternal morbidity or mortality event than white women. Within infertility, we also see that infertility services and treatment are not widely available, or at least quality clinics are not widely available to Black and brown women. And half the individuals who potentially could benefit from infertility services are Black and brown individuals. But overall, I think it's important to say a couple of different things. And these data come from a really important article by a Black gynecologic oncologist, Dr. Kimmy Dahl. I feel it's really important for us to lift up the work that people are doing in terms of providing us rigorous data and new ways to think about these data. It comes from an article she published in the American Journal of Public Health. And I'll end my comments with a quote from that article, which is entitled "Black Lives Matter, Claiming a Space for Evidence-Based Outrage in Obstetrics and Gynecology." And I'll put a link to the article in the actual chat box, but she says, "Enough is enough. Race is a social construct, and the overwhelming statistics that we present are attributable to a broken racist system, not a broken group of women." So I will end my comments there to be able to say that we need to really be able to look at the systems that allow these disparities to occur, as opposed to really, really blaming Black women and brown women and women of color for some of these outcomes.
Thank you, Monica. Zaya, would you like to add anything about social determinants of health?
Yeah, so I think that following up with what Monica said, I think it's important for us to recognize that these health disparities are more or less a reflection of other inequities that we see in this country that have been many centuries in the making. For example, Black women are disproportionately represented in bachelor's and master's educational programs. But despite that, what we know is that Black women earn anywhere from $400 to $1,000 less than their white and Asian counterparts with the same degree per month. Right. And so we often talk about this idea of, well, if individual women could just get more education, but we have a structural system-wide problem that even when women of color get more education, it doesn't necessarily turn into a financial benefit. So then it doesn't surprise me that we have huge disparities in both wealth and income in this country based on race. When you look at income disparities, the median household income for white people in this country is nearly twice that of Black household incomes, despite the fact that, as I already mentioned, Black women are overrepresented compared to population levels in educational programs. We also know, because of a number of historical and current factors, that Black families have an average wealth of around $2,000 when you compare that to the average white family that has an average wealth accumulation of around $100,000. And these kinds of disparities take a tremendous toll on all aspects of one's life, but particularly important to note the stress that it causes to A, be doing everything that you were told to do in order to be successful, but not being able to reap the benefits of all of your hard work in the way that your colleagues of other races are, but B, the actual stress and strain of living in poverty in a country that has no love for impoverished people is very stressful. I also want to point out that the Harvard Business Review recently did a review article of all of the hiring discrimination studies that have been done in this country over the last 25 years. And what they found is that there has been no significant change in terms of the amount of hiring discrimination that Black people face since 1995. And I think it's really important for us as a country to recognize that these health disparities are only a reflection of some greater disparities that we hold tightly to in this country, even as we increase our progressive narrative and we talk about how we're living in a post-racial society. A lot of these racist outcomes have been steady throughout. So if we really want to address this issue, we can't think of it as something as narrow as certain disease states, but rather recognizing that this is part of a much larger and much more problematic system.
Thank you, Dr. Malawa, Dr. McLemore, and Fatima also.
Yep. Before we go to the next question, can I make a quick point just to clarify some of the data that I laid out? The data that I laid out implicitly was about cis women, and we're talking a lot about overrepresentation in data. And I just want to make the point that trans women are systematically excluded from data, erased from data. And when we're talking about HIV in the United States, that's particularly harmful, particularly violent as well. So I just wanted to make that point. As we go through, I'll do my best to include that and just to remind us about kind of what's missing from the data that we have as well.
And I'm so grateful you said that, Fatima, because not only is that point an important one, I also think that everything Zaya said was exactly spot on. But I would also like to point out that pregnancy-related health disparities do not improve because of wealth. I mean, when we think about the public birth stories this year that were told by Serena Williams and Beyonce, these are women who are millionaires and billionaires. The idea that signs and symptoms of deterioration cannot be recognized by healthcare teams that do not believe patients because of racism is an additional problem. And so I think Zaya's point is spot on in terms of the other inequities that we have, but I also think it's really important that across the economic spectrum, the health disparities for Black and brown women do not improve.
Thank you for raising that point. What I'd like to do is share a quote that will set us up to talk a little bit about historical factors, which we obviously cannot spend a lot of time on, as we probably need to, but it'll get us thinking about some of this stuff in a historical context. And that quote is by Ta-Nehisi Coates, and it says, 250 years of slavery, 90 years of Jim Crow, 60 years of separate but equal, 35 years of racist housing policy. Until we reckon with our compounding moral debts, America will never be whole. And I want to credit Dr. Malawa's presentation for that quote. But I was hoping, Dr. Malawa, that you would share with us a little bit, what does it mean that we are striving for equity in all forms while steeped in injustice? And what can you tell us about the history of the construction of race?
I mean, there's so much to be said on this topic, but one thing that's been on my mind lately is really the way how throughout our entire history in this nation, we have seen this operationalization of racism as a way to keep all low-income people down. When you think about when this country started, there were a bunch of wealthy white landowners who came ready to exploit Native Americans, but also exploiting a number of low-income folks from around the world, low-income white people and low-income Black people. One of the challenges that these early wealthy white men in this country had is, how do they prevent all of these working class people from forming networks of solidarity because they greatly outnumbered the white owning class, and there wasn't infrastructure in this country such as a standing police force or standing military to be able to suppress any rebellions. And so very early on, what we saw was that first division where there were 3 indentured servants, 2 white, 1 black, and they all ran away from their master because they felt like it was unfair treatment. What ended up happening is that all 3 of them were being caught, but for the very first time, we saw a differential punishment based on race. The 2 white men were sentenced to serve an additional 2 years to their indentured servitude, and the black man was sentenced to a lifetime of servitude for the same crime. And basically what that was the very first time that the white earning class decided to mete out punishment differentially based on this new concept of quote unquote race, as a way of making sure that there was no solidarity between white working class people and black working class people in this country, which would be a threat to the leadership and the establishment. We see the same pattern happening over and over again. We see it happen upon the emancipation of slaves, and that was when early on a lot of this convict leasing and Jim Crow laws cropped up, yet again to make sure that the white working class felt that they were somehow elevated above poor black people. And so this injury that continues to happen to black people is very much in the service of maintaining white supremacy and the white owner class, and allowing them to maintain their authority. We continue to see this throughout history. So we see even with Nixon's campaign, basically what he was able to do is he was able to put racism in play in such a way that white working class voters were ready to vote against their best interest and undo a bunch of the New Deal programs in service of racism. And we see it today, obviously, with Trump. Yet again, we see him passing these tax cuts that are harming the white working class greatly, and yet they are avid supporters of this man who is devastating their lifestyle because he is serving this racist agenda. And so what ends up happening in this country again is that all of us are injured by supporting the system of white supremacy and by supporting racist outcomes. But throughout it, what we also see is that people of color, of course, are really holding the greatest burden of this injury because the injury is cumulative throughout history. And when we don't address it, not only does it alienate all of us from our shared humanity in this country, not only does it make us liars as we try and put ourselves out there in the rest of the world as the bastion of liberty and freedom and democracy, but it also robs us of our own economic future because we are wasting in a huge way the human capital, the incredible creative potential of entire swaths of the population in service of this very small, wealthy white ownership class and their well-being. And so this entire country suffers every time we choose racism, every time we choose to not repair the injuries that have happened in the past, but rather progress this very racist system.
Dr. McLemore, Fatima, any thoughts on that? Or any thoughts of?
Yeah, I mean, I think Zaya's outlined sort of pretty well, you know, sort of this larger system that we all function in. But I think there's another piece that we all can uniquely contribute, which is this idea of how we think about health and how we think about wellness, right? I mean, our healthcare systems and our healthcare institutions, and particularly those of us who work within those systems, are not immune to all of these other systems. And so, you know, we ourselves also have to hold ourselves accountable for how this manifests and how this shows up, whether it's in health services provision or it's in the scientific enterprise. One of the reasons why when people ask me all the time, I have such a need for the diversification, of the healthcare workforce, it's not just because I think that we should have people of color taking care of other people of color. We know how to do that. The issue is there's structural power behind being able to set a research agenda, to determine how research dollars are spent, to determine how healthcare dollars are spent. The idea that people think about public insurance and Social Security as entitlements is really problematic. We'll never not be able to have a conversation about what supports do all people need in order to be able to bring forward their gifts and talents in the universe if we're thinking through that some people are more legitimate than others, and some people deserve investment and other people's don't. I just think that it upends, racism keeps us from having a more authentic conversation about what does everyone need in order to be successful. as opposed to everybody should get what everybody else should get. And that's one of the real sad pieces, I think, that racism does. It does not allow us to have a unique conversation about how can we get everybody the things that they need in order to be successful humans and to live a whole, full, and healthy life. And within health systems, I think we're very blind to not understand that we have a role to play in that. And I'm hoping that we can inspire people to play a different role and to have a different conversation about how we can make strategic investments to make sure people can be healthy and well.
Absolutely. And I think that the only thing that I would add to what's already been said is, how racism is almost this, it spawns so many other ways of oppression, right? So when we're thinking about racism as this kind of backdrop, we also understand that sexism is also racialized, right? And homophobia is also racialized, and transphobia is also racialized. And so classism as well. And so when we're thinking about all of the different ways that people are denied access to healthcare, all the different ways that stigma perpetuates as well, it is with this backdrop of racism and all of the, almost like a hydra, all of the different heads that it holds.
Let's talk about current challenges, and Fatima, I'll keep it on you to share with us some examples of current policy issues that are affecting the women of color that you care for or that seek care at your agency or in your programs. What are overall sort of policy issues that are affecting women at this moment?
Yeah, that's great. Thank you. It's funny because oftentimes when this question comes up, people are saying, your clinic services at BAI are based in California, which is, often referred to as kind of a health access haven. Medicaid was expanded and all these other great programs. But at the same time, again, if we're understanding holistic access to health, we have to understand that the public charge proposal that just came out of this administration that would basically say that folks are ineligible to apply for citizenship if they use public services deeply affects communities, especially immigrant communities, and not only people who would actually be affected by that, but also just this general anti-immigrant sentiment. We do free HIV testing in our clinic, and I think maybe once a month somebody says, where it's amazing that this is still able to happen because so many folks are so worried about coming to a place that might have any medical records because of this anti-immigrant sentiment. I think similarly, anti-policies that are over-policing communities, whether that's for low-level charges like skipping the fare when you're going on the subway or public transportation, or petty drug issues. All of those also affect communities of color, also affect women of color when we're talking about seeking care. So it's always important to consider kind of the long breadth of how policies affect just people's daily lives and whether or not that means that they're going to be able to get not just the actually care, but also information about that care, whether or not they're going to see a space as a place where they can go and have confidential conversations about their health as well.
Any thoughts, Dr. Malawa or Dr. McLemore?
I could say a million things about health policy and how policy impacts how we think about, not only the health and well-being of our citizens, but how racism intersects around that. So I'll try to keep this brief. I mean, everything from the fact that we have a possibility of LGBTQIA individuals not being uniquely and specifically counted as part of the census really only gives us an incomplete picture of like the health of our citizens, right? When you think about border separation, I mean, as a longtime nurse in reproductive health, it drives me crazy that no one could make the argument that we would never separate moms and babies or families in the hospital. In fact, we fought for dyadic care for years to keep moms and babies together. This whole idea that somehow we would allow that to happen in community is really problematic, and that no one tied those pieces together really sort of makes me nuts. Building on what Zaya talked about in terms of economic opportunity and lost and wasted resources, we should not, it should be a no-brainer to have a conversation that paid family leave should become the norm in the United States. I mean, I work with individuals all the time who have jobs in the gig economy going back to drive for Uber and Lyft a week after they've had a baby because they have to make their rent, right? And so, that we don't have a basic minimum income for citizens and for individuals who are poor. We're getting to a point where families have to be wealthy in order to be able to be a family because we don't have the social safety net to be able to support them to parent with dignity. The entire idea that Title X, the family planning program for low-income and disabled individuals, that we even have to have a discussion about whether or not people should have access to the full range of FDA contraceptives, both medications and devices, is just absolutely stunning to me. But again, if you don't have a justice lens thinking through what should be available to individuals, then we're not going to be able to have a conversation about how to maximize the gifts and talents of all of our citizens and to be able to create the world in which we want to live. I also think one of the hard things that I think we need to deal with is this idea across the reproductive spectrum that our system is broken. I mean, we need to be able to have doulas, we need to be able to have midwives, we need to be able to have ambassadors, we need to be able to have access to medications, devices, all of the things that we need in order to be able to participate as full citizens in society. And the idea that people think that people who need contraception and that people who need these things in order to be able to do things like advance our education and to be able to fully participate as citizens in society, to deny us of those things states that we're not worthy of being fully human. And so I think racism allows us to not have deeper discussions about the fact that everybody needs different things in order to be successful, and that how are we going to make that happen in an equitable way?
I think what I would like to add is that I think one of the things that our patients are up against is really what I'm going to call everyday racism. I know that the detaining of immigrant youth has garnered a lot of news attention, as well it should, because it's an atrocious policy. I also want to point out that in San Francisco, 62% of detained youth are Black, even though we make up only 3% of the population. And this is not a new statistic, and it is not getting any newsworthiness. I deal with a number of immigrant Latino families who are separated long before Trump came into office, and they're separated by the economic pressures that this country puts on Central America, forcing moms to leave their babies behind just so that they can figure out how to support their kids. And that's not in the news, and so we're not talking about it. Something that has been really challenging for me since I started working here in a government setting is that people don't want to dedicate the time and resources that it takes to start to address structural racism and interpersonal racism, despite the fact that it has tremendous costs, both human costs and economic costs, to not address it. Health disparities are not new in any of our health departments, and yet what I have found is that our health department is much more likely to commit resources towards lean management or, employee retention among physicians, as opposed to this thing that is literally determining whether or not folks of color are going to live or die. And so I think that we have a challenge, my clients and I have a challenge, is that this conversation around really understanding racism as a root cause and what we're going to do in order to address it as a root cause is not happening. And it pops up every once in a while when something very controversial happens in the news. But meanwhile, racism has been around for centuries. And so it's going to take a concerted effort with a lot of resources to address it. And these conversations just don't seem to be happening.
So let's talk a little bit more about what it means to have these conversations and switch gears to kind of address the question of how do we center the leadership of women of color towards health equity while understanding that the burden of change falls on all of us, given that our audience here today are folks in public health, health practitioners. What does it mean for us all to be in this together while centering the leadership of women of color, but not expecting that that's where the change is going to come from only, or that the burden should lie among women of color? So if anyone wants to give us your thoughts on that.
I'll take that one because I think a lot about this, and I think it's super important that this be said. The two largest employers in the city and county of San Francisco are the city and county of San Francisco and the University of California at San Francisco. I'm a faculty member. And as publicly funded anchor institutions, have a real responsibility to think through not only our hiring practices, but also our policies to understand that the people that we serve are the greatest investment in our future workforce. And so this whole idea, I would love, and people look at me and they give me a side eye when I say this, but I'm gonna say it because that's just who I am. If we could understand every open position that we currently have between the city and county of San Francisco and the University of California, San Francisco, and to try and match community members with those positions, making the real commitment to make sure that they have the education, training, and supports that they need to be successful in those positions, then we could actually have a natural experiment to understand how to improve and partner with community to improve community. Because not only would they be our employees, they'd also be people eligible to seek health services at our institutions. So I would like to challenge us to think really, really boldly around how could we address structural issues with structural solutions, as opposed to asking individuals to make sure they go to City College and do all their prereqs and do all of these other things as individuals. What structural things could we change to make this seamless and helpful and bold at a process level to be able to maximize our commitment to improving outcomes across the board for everybody?
So I would love to piggyback on what Monica is saying, because I often enter a space where I am a relatively outspoken Black woman, and people often feel like, therefore, it is mostly my job to change the racist systems. And I want to remind everybody that, in fact, it's all of our jobs to change the racist system. And if anything, I would actually say that because throughout this country, most of the positions of power are held by white people, then it's actually probably more white people's job to change the system than it is mine. And that's not to say that I shouldn't have a very front and center seat at the table, because I hold some knowledge based on the fact that I grew up in this skin, in this family, in this communities my whole life. I might know some things that the people who are usually at the table might not know. So I definitely need to be there. But I don't think that realistically, women of color alone are able to do this. So I want to kind of spend a second just talking about some of the things that all of us can do, but in particular, those of us who hold the keys, who have the power, even if it's small. And so one thing is kind of what Monica was talking about, which is like really looking at what it would look like to diversify your organization's workforce at all levels. So many times I go into nonprofit organizations and their frontline staff is mostly low-wage workers of color, and their leadership is mostly white people for the most part. What does it look like to diversify across? Something that we've been thinking about a lot in my organization is, what does it look like to make sure that we are using our contract dollars and other kinds of outsourcing to support marginalized communities whenever possible? Because for, again, centuries, we have had in place a system of white affirmative action. So what does it look like to therefore do some restoration of these problematic systems? I think that at every single point, each person in their institution can either apply pressure, if they are not in leadership, to make some of these changes, or they can make them themselves if they have that power. And that is every single person's job, and that is something that can happen right at this moment. In general, I know that we are doing meaningful work if we are shifting resources, power, and opportunity from communities that have been historically privileged to communities that are marginalized. So we shouldn't be thinking about how to form more working groups. We shouldn't be thinking about certain kinds of frameworks that we need to establish first. We really need to be thinking about action. And what action looks like to me is shifting of resources, opportunity, and power to marginalized communities. And there is a role for every single one of us, no matter where you sit in your organization, to be working towards those goals.
Absolutely. Thank you both so much. I want to reiterate what you were saying, and I also want to focus on, how important it is for those of us who are looking to diversify spaces, whether that's according to gender identity, whether that's according to race, to also think about what work we need to do beforehand before we're inviting people into this space, right? So how are we making sure, if we are in leadership positions, if we already have a seat at the table and we're trying to expand that, how are we making sure that when somebody new comes to the table, they're not going to be tokenized? What are we actually doing to make sure that whatever involvement that folks have will be useful, will be meaningful, will, what structures are in place that will help them actually reach their goals, rather than kind of inviting somebody to come in and do the work of telling us how we need to be better before they can even do that work. Because there's so much labor that goes into that. There's so much unpaid labor of making a work environment, a working group environment kind of just accessible, that it really falls on us who already have the privilege of being there to be able to do that before we're bringing other folks in.
I just want to take a quick second to honor how much unpaid work goes into the world just by the 3 individuals on this Hangout today, and how much we need to honor and pay for that time on an hourly basis. So just putting that out there.
I'm sorry, I have to say something to that because I was laughing on mute. I think the level of uncompensated labor that people of color do more broadly is really the unspoken, real injustice that really can be minimized and not continue to be perpetuated. Again, if we diversified our healthcare workforce. I know this is probably true of Fatima and Zaya, mentor students at my own institution, at other institutions, because there's just not enough of us to be able to go around, to be able to bring, and there's not enough faith and enough belief in community expertise and wisdom that's seen as valid and legitimate. I'm gonna need everybody to understand that those things exist and that you have to be able to not only trust it, but invest in it.
I'd like to switch gears again and discuss a little bit about, discuss some frameworks. Can we start by talking about reproductive justice? We know a little bit about what reproductive justice is, Monica, from your bio itself. But what does this mean? What are the implications for the work that we do?
So I have been wholly convinced by many of the elder and foremothers of reproductive justice when I think about Len Roberts and Tony Bond Leonard and Loretta Ross and Monica Simpson and the folks from Sister Song, Sister Reach, and Sister Love, to really understand that reproductive justice is a roadmap and it's a human rights framework. And it really helps us to maximize all of the gifts and talents of the human species. And I think if we start from a place that sentient beings and have the absolute right to be able to decide in the context of their own lives as experts by experience what's right for them, that changes the kinds of discussions that we can have about things like policy and resource allocation. So let me give you a perfect example about this. I mean, one of the cases that's being heard by the Supreme Court this week is really about the rights of immigrants and understanding what rights do immigrants have, and really trying to delineate that. From a justice perspective, that wouldn't even be a conversation, because there would be this inherent acceptance and acknowledgement that people have a right to the reproductive destiny that they so choose. So how we spend money, how we invest time, and how we develop humans, as Zaya so clearly laid out for us, is a form of power. And so from a justice perspective, it would really acknowledge that every person has a part of that power. So from where I sit, it is really difficult to not allow provision of clinical services by people who are safely trained, whether that's doulas or home birth midwives or midwives who work in institutions, to be able to provide care and support across the reproductive spectrum. Scope of practice battles for advanced practice clinicians, to me, is the perfect example of a power grab by a particular discipline. And it's problematic for a whole variety of reasons. So that as we think through, again, having a very workforce lens, if people can't gain access to the services that they need in order to be able to maximize their reproductive life, then to me, that's not a justice approach to understanding how we should set up health services and how they're provided. So I think reproductive justice is a way for us to think through, especially in murky times like now, because it's very clear. It always centers making sure that people get what they need when they need it in order to be successful. So we wouldn't have conversations about whether or not telemedicine is something that we would allow for, let's say, cardiovascular disease, but we won't provide it for contraception. Or that there are certain populations that we will provide services to specifically if you can afford them or not, like we do with infertility treatment. There would be an understanding that whether you have public insurance, whether you have Kaiser, whether you have employer-sponsored insurance like Blue Cross or HealthNet, that there would be some consistent standards that everybody would provide for everybody, and that those individuals who needed it at different time points could be able to access those services irrespective of who was paying for it. That to me is the importance of reproductive justice. It sort of allows for the flexibility that everybody, there's a shared agreement that there's a set of things that everybody needs in order to be successful, and that everybody may or may not take advantage of those things across their lifetime. And that's okay, because we understand that reproductive well-being is essential and a public good. That's the conversation that RJ could help us have. And that's why I think it's so important for us to be using now.
Any other panelists want to share on reproductive justice or justice in general? We've talked about justice-rooted work, social justice, reproductive justice.
Yeah, I want to talk about justice also, because I think that one of the things that I often think about that frames my work is around systems change. A lot of us do work at a program level, and I think program level work is really important because injuries are happening to communities right now, and those injuries need to be addressed. But what I think often gets forgotten in our program work is this piece of justice, because if we're doing our program work well, we should be putting ourselves out of business with our programs. And instead, all we do is find more and more need for more and more money to continue to expand our programs. One of the challenges with this model is that so often our programs are implemented and led by people not of the marginalized communities. And so when we draw down more and more resources for these programs, those resources are not actually reaching the communities that deserve them and need them the most. And so I think that the Panthers used to talk about, the Black Panthers talked about this idea of survival pending revolution. It's this idea that we have certain services in place to help our people survive, but only in the service of revolution, not in the service of maintaining the status quo. And so what does it look like for us to start to not just think about survival in our programs, but also the revolution part of it? And that's where the systems change comes into my mind. And all of us have a role in systems change. It may not be during your actual work. As a government employee, I'm not allowed to do advocacy during my actual workday because I'm funded by taxpayers, but that doesn't mean that I can't take a day off of work to go and talk to policymakers, because I hold a very important perspective, being that I am on the front lines in my work and that I'm seeing things that policymakers are not. We can also be writing letters to the editor. We can also be advocating for structural changes within our own organizations. So what do policies look like that start to change how we do recruitment and hiring? And how can we change those so that they support the right people? What does it look like when we are getting money for caterers? How do we make sure that our contract systems are structured in such a way? What internal policies do we need so that we make sure we are resourcing the communities that need these resources? And so when we're thinking about this work, it's really important that we don't just think very narrowly in terms of the actual service delivery, because that is one piece of the puzzle, but it's only one piece. How do we keep justice in mind in every single aspect of our work to make sure that we're constantly thinking about what would it take to put this service out of business so that we no longer need to exist?
I just love everything that you two are saying. And I think just to kind of add the frameworks that, in addition to what you two are saying, two things that I think about often in my work are, first of all, the Kambi River Collective, right? Black women are inherently valuable, not because Black women will save us, not because we should listen to Black women, not because Black women show up to the polls. Exactly, yes, that book. But because we are inherently valuable. And so we understand that we're inherently valuable, and we take that and we apply it to other marginalized folks as well, and that inherent value then it's not just a question of, how do we make sure that this person is getting into care for HIV treatment because we don't want them to, pass the virus to somebody else. It's also, how do we make sure that that person is living their best, healthiest, fullest life, right? And that is enough. So I think that I think about often. And I also think about this conversation about systems change. I've been thinking a lot about Afrofuturism and what that means for us who do health work. And so if you think about it in that, from the first moment that Black folks were forced here through slavery, we've been creating technologies to stay alive, right? So whether that's creation of language, like Haitian Creole or Patois, whether that's creation of music, of faith systems, whatever the case is, we have been adapting and making technologies for us to survive. And so when we think about the future and we think about the changes that need to happen, what technologies are we going to be creating that's going to ensure not only our survival, but also our flourishing, also our thriving? And if we're taking the idea that the master's tools are not going to dismantle the master's house, right? How are we broadening this to thinking about what do we all need in order to be living our best lives in the future? So I think that kind of just dovetailing on what was already said kind of guides a lot of my work when I'm thinking about this as well.
One thing I'd just like to add, as a person not of African descent, as a woman of color who is not of African descent, how can we be curious about each other's histories? How can non-Black people be curious and learn about Haitian Creole, about Patois, about the history of faith, the history of the hands that have built the United States? So I just want to add that.
Wait, Yamini, can I add something to that then? I want to, since we're having this very important and honest conversation, I want to talk about the importance of solidarity among oppressed communities, because one of the most important tools that white supremacy has created to ensure its own survival is this idea of us dividing up around interest groups, when the reality is that we have one very important shared interest, which is that we all want to live our best lives, right? And it's the same issue underlying, although it has different manifestations, it's the same issue underlying those barriers for all oppressed communities. And I just want to say out loud that many people might come into this work with a number of biases. I know here in San Francisco, within the immigrant community, there is a lot of anti-Black bias. I know within a lot of communities of color, there is a lot of anti-LGBTQ bias. But what does it look like for all oppressed communities to recognize that we will no longer be serving white supremacy by buying into these biases and instead do whatever the work is, whether it's learning history, getting to know people, but whatever the work looks like so that we can be moving in solidarity. I often think about the statistic in California that we're going to be majority minority in just, a few decades. But the challenge is that as long as we as minorities think of ourselves as Indian and Korean and African American and Chicano versus Latino and all of these things, as long as we are divided like this, then this majority minority means nothing because it doesn't carry power. And so I want to expand on your question that it's not just what does it take for us to be curious, but really what does it take for us to be moving in solidarity around issues that impact all of us?
There's a million things I could say about this, but I'm going to keep this brief. I think that non-Black people of color have some work to do. And I say that in the context of, one of the other SCOTUS cases that will be heard this week is the case that's being brought forward at Harvard University around the perceived notion that Asian Americans are being discriminated against around admission, and then pitting sort of other people of color against each other. And then around this sort of, basically we're lowering the bar for other underrepresented minorities and we're raising the bar for us. And so I do think that there is this deep need to unpack and interrogate, sort of the anti-Blackness that happens, because I actually think that that's built purposive and a whole part of white supremacy. And anti-Blackness is crucial and essential for it to continue to exist. And so there's this unique opportunity and this unique challenge that people can have to sort of look at their own anti-Blackness. What messaging have you been told by systems that are racist that actually really are not helpful? I personally also think we need to get back to teaching some very basic information not only to healthcare providers and healers, but, to citizens, to really, really understand that, there is a long documented participation of people of color in the human enterprise. I mean, I've been on multiple threads recently around even just decolonizing syllabi so that we can read more in our learning institutions from the contributions of people of color. So this erasure isn't just, I need to show up and sit at the table. The erasure isn't just, I don't want to sit across from non-Black, people of color who harbor anti-Blackness. But there's also this whole other piece around what are the teaching and educational pedagogies we're using within our own institutions to understand how we also reinforce and enforce anti-Blackness, and starting from there. Because it's not about an elitism thing. If you don't understand the relationship of anti-Blackness in the propping up of white supremacy and racism, then we can't even begin to have a conversation, because it's not about a us or either them. Anti-Blackness is essential for whiteness and white supremacy to exist. Does that make sense?
Absolutely. Can I just throw a quote out there by Dr. Dorothy Roberts? Race persists because it continues to be useful. And I think you just hit on that in a variety of ways. I want to bridge this back to ask the question about what does it mean to be an ally? And kind of taking what we just talked about, what does it mean to build? There's a lot we just learned today. There's a lot to think about here. What does it mean to build those bridges and to show up as an ally in this work? Anybody want to start that?
So I want to add at least one piece. I mean, there's a lot of what it means to be an ally. One thing is I would question this terminology of ally, because it assumes that white people don't have to be at the center of this work and that they get to kind of drop in when they feel like it. And that feels problematic to me. So part of it is really recognizing that this is not just something that impacts communities of color, or that communities of color are the only ones who have to work on this. So I would say not an ally, but what does it mean to also be in the struggle for everyone's humanity? And one of the things that I want to say about that is that I feel like very often white people think that it is their primary job to prove to people of color how with them they are and how much they are about this work. But I actually think that to really be involved in this work with skin in the game, white people's job is actually to show other white people how much they are in this work and really work on their own community in terms of addressing anti-racism. However that looks, that might look like talking to your leadership, that might look like talking to your CFO, that might look like talking to your granny, but whatever it looks like, it really is about doing the work, not just when you are a white person in a community of color, but doing the work within your own community, because that's really where it needs to happen.
Absolutely. I think that work of ongoing humility, that critical self-consciousness, is so necessary for folks who want to be in solidarity when it comes to doing this work. This whole country is set up for us to perpetuate racism and sexism and all of these things. So it takes an active role, it takes an active decision to, not do those. And that can be in, kind of the smallest decisions and the smallest actions that we take. But again, it takes being in that space of constantly thinking about, what am I doing? Why am I doing it? Just because it's always the way that it's been done, whether that's an organizational protocol or how you interact with other folks, that's not good enough. We have to take the time to examine why it's always been done that way, what harm is perpetuating, and decide, what can we keep and what do we need to get rid of.
And I'm not looking for allies, I'm looking for accomplices.
Can you say just a little bit more about that?
Well, accomplices are people who are willing to drive the getaway car with you.
Enough said. I'm going to take 2 questions from our audience here. Go ahead. So I think, Monica, you spoke about the deficit model in public health and just data-related conversations. How do we shift the deficit model into a strengths-based or strength-oriented model?
Very quickly, we decide that empiricism isn't the only legitimate form of research, and that we lift up both exploratory and participatory research methods to hear the voices of individuals. We need to change the method in the way that we collect the data and the science, because otherwise, if we keep trying to quantify things, we won't get anywhere in terms of our understanding of how to understand why Black people are not extinct, as opposed to continuing to map our health disparities.
Anyone else have thoughts to share on that? There, you're on mute.
I think that often I can't use the Google Hangouts. I think that often we focus very much on the disparity, and we don't think about what is being prevented, right? So often we look wholeheartedly at the number of people, say, with college degrees based by race, and we might find it short, but what we are not therefore focusing on is what actually produced that. And what ends up happening is that we negatively reinforce certain mental models about deficits at the individual level, and instead of understanding the structures that determine it. So I think that one really important way to focus on deficits is not just to focus on the deficits of the target population, but rather the deficits of the system in terms of making sure that everybody can be healthy. And so every time we refocus our lens from when we're thinking about deficits from people and communities to structures and systems, because there are certainly deficits there that need to be addressed, I think that's where we start in terms of an important switch or transition.
And I think part of that shift is understanding that oftentimes, most times, communities understand what barriers are in place. Like, we know what is ailing us. And so starting from that space and having the conversation of, okay, tell me about your experience, tell me, what were your barriers? And recognizing that kind of almost every answer to that question is also going to be a how I overcame that barrier, and start from that understanding. I think folks know what they need to continue to overcome barriers. They know what they need to get those barriers out of the way completely. And starting from that place is that important shift as well.
And of course, we heard from you all about this question, but another question was, how do we center leadership on people of color of health towards health equity, but also without placing the burden on us to ensure this change? We spoke about this, but any other thoughts on this?
One thing that hasn't been said that I think is really important is that when we invite people of color to the table to give their perspective, we need to pay them. If we are going to have an engineer come to help us figure out how to be earthquake safe, we pay them. If we are going to have somebody come and help us with our data by doing an evaluation because they have statistical expertise, we pay them. We value the knowledge of community in creating effective programs, and therefore we need to pay for that knowledge as well. And so while that's not the only answer, I think it is an important answer, is to not always assume that community participation should be for free.
If we really want to achieve health equity, every department should have a paid co-director that's a community member.
I just want to echo the paying people.
Always a good start. We're going to close out here today. This is going to be a hard question for anyone to answer. But I'm wondering if you all can think of one thing folks can do to impact change as they leave here today, right now, after this talk.
If you go online and Google racial impact assessments, what you can find is a series of 8 questions that can help you evaluate any future or current policy to understand what the differential racial impact is. Every single person on this call can take a look at their hiring policies, their recruitment policies, their employee retention policies, some of their patient care policies, and take it through this racial impact assessment to kind of understand where your organization has room to grow, and then implement an actual action plan with a timeline and resources to fix that. And that is one thing that every single person can do starting now.
There's like 257 people on this call. If any of you are hiring managers, make a commitment to make sure that you will build a path to our health work and the health professions for your next employee, and make sure that person is super supported in their work, and develop a paid community advisory board to your organization, all people of color.
I would say that for folks who are in leadership positions, have meaningful conversations with frontline staff about what needs to be changing in your organization, and whether that's a question of having more folks of color in leadership, whether that's a question of making more paths to leadership for frontline staff. Ask those questions and take them into account, make changes based on recommendations. And for frontline staff who are on this, I would say, if you can, try to organize within yourselves to kind of make those recommendations, and continue trusting yourselves and fighting the good fight.
Fatima, I especially want to shout you out for that last piece of the frontline workers. I think often many of us are just at a loss of what to say, what to do, what not to say, what not to do, because we want our paychecks, we want our lives, we want a career. So thank you very much for that. Thank you to everyone for joining today. This hopefully is the beginning of this conversation and definitely not the end. Please look out for an email, follow up with lots more information and resources from our panelists, as well as other resources. I want to close out with a quote by Audre Lorde, and that is, "I am not free while any woman is unfree, even when her shackles are very different than my own." And with that, I'll close out. This was Hangouts with HIVE.